Okay, flip onto your back again for me. Okay, so we've done sensation and motor testing. For deep tendon reflex testing, there is some argument about how this should be done. And one of the recommendations is that you repeat the test half a dozen times on each tendon. There's a couple of problems with this. The first problem is that repeated striking of the tendon tends to facilitate the reflex. So, and any of you who have done any neurological work know this. If you have a flaccid paralysis, you slap the area to get the patient to contract. The same thing can happen here. So it's possible to turn a hyporeflexia into a normal or even an overly brisk one. The other problem with repeated testing is that the ability to hit the tendon in the same spot with the same amount of force 6 times in a row is beyond me, and from my experience, beyond most other therapists. So for the sake of the majority of us, we're not going to do it that way. What we're going to do is we'll do up to three reflexes. If we get a good contraction in the first one, that'll do it. We'll move on. If we can't get a contraction or it seems too weak, then we'll repeat it up to about 3 times. If we haven't got it in 3 strikes, either the patient has a hyporeflexia or we need glasses. One thing you don't need to do is keep on hitting them. So when we're doing these tests, we're looking for hyporeflexia, which would suggest a lower motor or a lower sensory palsy. And again, the distribution of that would tell you whether it's segmental or whether it's a nerve, a peripheral nerve. We're also looking for true neurological hyperreflexia, where there's some sustainment of the contraction. Now remember that we're not dealing with overt neurological patients. These are orthopedic patients that may have central nervous signs. So we're not looking for that shuddering effect as much as a slight sustainment and a little bit of clonus with the reflex and the response to it. But it will certainly be much brisker. But then brisk reflexes can be from a variety of reasons, including segmental facilitation. So, looking at the reflexes, we don't have to concern ourselves just with the standards. Any muscle with a spindle has the potential for a reflex. Some are more difficult than others, but they've all got the potential. So we'll start from L3, as the patient usually doesn't like you banging around into the groin area trying to get L1, 2. And these can be done in sitting, where they're a little bit more sensitive, or they can be done in laying, where it's a little less sensitive, and you need to be a little bit more practice at getting the reflexes. For me, doing them in sitting feels awkward because I've never done them that way, so I'm going to demonstrate them in laying, but remember they can be done in sitting. So for the knee, just relax there for me. Good. We'll just come back and let the hammer just do the work. Just drop the hammer onto the tendon. Okay. So we've got L3, basically L3. We can check another key muscle for L3, which is the adductors. So you just come in, put your finger on the adductor magnus tendon and hit your finger and look for a response in the adductor. I would need to come around the other side of the bed to do the other one, so I won't worry too much about it. L4, there's a couple of reflexes we can do for L4. Tibialis Anterior. We'll hit it somewhere around the middle of the belly, and we'll look in front of the ankle to see if the tendon flickers. So it's that. And you can actually see her foot moving as we do it. The alternative for this would be the tibialis posterior, and you just strike down on the instep of the foot. And would you know it, she hasn't got one on that side. Try this one. Relax for me. Good. And we've got one on that side. Actually quite a nice one on that side, but not on this. Maybe it's because she wasn't relaxing. Just relax again. No, that one's definitely down. L5. Again, we've got a choice. We can take the peroneus longus, or at least one of the peronei, I'm not sure which one it is we'll hit, but the peronei, and just strike in there and watch for the foot to evert. And we can come down onto the extensor digitorum muscle and look for the tendon to just flick the toe. For S1, we can come in this way and hit on the gastrocnemius tendon, the tendon of Achilles. And my guess is that she won't have it on this side neither. Relax there for me. Oh, she will have it on this side, not that side. So, there, yeah. She's got one there. So it looks as if it's probably L5. If it's a palsy at all, it would probably be L5, because we're finding that although the tibialis posterior is L4, it's also L5, and although this is S1, it's also L5. So we're probably looking at an L5 problem there, if there's actually a problem. We can use the hamstrings to test the reflex as well. Now, for some reason or another, the medial hamstring is considered L5, the lateral hamstring S1, S2. I'm really not sure the rationale behind that statement. What I'd suggest is that you consider these hamstring tests as possibly being anywhere between L5 and S2. The medial hamstring reflex is easier to get than the lateral. So looking at these tests then, for the medial hamstring, you just put your finger on the hamstring tendon, flex the knee up, and you hit your finger there, and you look for the contraction in the belly of the muscle, and also to see if you can feel the tendon kicking under your finger. For the lateral, you do it from the opposite side of the bed, flex them up again, just relax there for me, Beverly, and again, hit your finger and look for that reflex. As I say, the lateral one is more difficult to find. When we're testing the ability of the spinal cord to inhibit these reflexes, we have certain tests there as well. The first one is obviously the deep tendon reflexes, where a spinal cord or other central nervous system problems will produce hyperreflexia with that clonic component to it. But we can also use clonus itself and try to produce clonus directly with a dynamic stretch, and we can use the extensor plantar response. Now, to get the extensor plantar response, we apply a noxious stimulus to the lateral border and ball of the foot. And this is a weight-bearing surface area of the foot. It's got to be deep enough to produce a sensation of pain, but not deep enough to produce blood. They tend to object when you do that. And what we're looking for is down-going toes, like so. A positive test is where the toes splay and go upwards, and this is part of the flexor withdrawal response away from a noxious stimulus. No response at all indicates nothing, okay, and it may be a sensory deficit, or it may just be the way they work. So that's what we're looking for, that splaying upgoing toes. Now there's an adjunct test that confirms that, and this is Oppenheimer's test, where you come in and apply a painful stimulus to the mid-shaft of the tibia, and you pinch it very hard, which I won't do to Beverly, and you look to see whether you get this reversed response, that is upgoing splaying toes. That would be the abnormal. The normal response is no response at all, or maybe the patient sits up and slaps you in the back of the head. Okay, for clonus, it's a sustained stretch, so we'll just stabilise the leg there, come onto the ball of the foot, push it fast and hard up, and hold it up, like so. And we're looking for up to about 3 beats. Anything over 3 beats is considered abnormal. However, if the patient is looking up at the time you do this and they've got their head flexed, you may well find you've got an extra beat as they do so. And this is probably something to do with the tonic neck reflex. So I'll get Beverly to look up and then put her head down, and we'll see what we can find. So this is with her head down. We've got 2 beats. Head up for me, Beverly. And now we've got 3 beats. Head down again, and 2. So if the patient is looking up when you do this test and you don't allow for this, and they're already at the upper end of normal, that is 3 beats, and you're picking up 4, you're likely to consider this as a positive test. The other place that you can do or test for clonus is at the patella. And basically all you do is you pull the patella hard down towards the feet that way and see whether you're getting a clonus response. The problem with this is there's a tendency to grind the patella against the femur as you do this, and obviously that's going to elicit a lot of pain. So if you can get it all from here, it's a lot easier on the patient, and the test is probably more sensitive because it isn't painful when you do this. Okay. There are, of course, other tests that you can do for central nervous system dysfunctions. Proprioception tests, such as putting your heel on your knee. Close your eyes, put your heel on your knee, and down. Good, and then put it back again. And we're testing for proprioception here. We can test for vibration using a tuning fork, just striking the tuning fork and applying it to the bone and seeing if you can feel it through. But these are very specialised tests, and in the run-of-the-mill practice for an everyday occurrence, these are not tests that you're going to find yourself doing very often.